Okay. All right. So the main things that I wanted to share with everyone is just kind of an overview for people who might not be familiar with harm reduction, what it is, and how I've used it in CBTp, and how it might be utilized for other folks. The reason why I wanted to do this is because it's a pretty effective strategy for people who are not ready, willing, or able, quote unquote, to stop using. And I think there's a lot of emphasis on, for people with psychosis, that they shouldn't use any substances. But we know that a lot of people do. And some research from fairly recently was that the stat was 50% of people with the diagnosis of schizophrenia could meet criteria for a substance use disorder. So it seems like it would be an important, it's important to think about how we might be able to serve people that are not ready or willing or able to stop using. Basically, for people who don't know, which I'm sure a lot of people do, but harm reduction is a term essentially that was, or a movement, a grassroots movement, actually started way earlier than the 1990s, but kind of came of age, I think, in response to IV drug use and HIV transmission. And so the Harm Reduction Coalition says that harm reduction incorporates a spectrum of strategies from safer use to managed use and abstinence, and sort of meets people where they're at, and sort of addresses conditions along with the use itself. And it demands that interventions and policies are designed to serve drug users, that they're reflected in the individual and community needs. So Seattle's response to harm reduction might be different than Yakima's response. That there's no universal definition or formula in implementing harm reduction, but I did throw together some of the things some interventions that you might use in harm reduction. But my favorite thing about harm reduction, which is why I love it so much, is it's described as an attitude of compassion and pragmatism, and not necessarily a set of very specific techniques, and it focuses a lot on quality of life. And as a person trained in social work, that means a lot to me. So some of the interventions, though, you could use would be active listening, which is a huge part of it, and understanding goals. And it really talks about, in harm reduction, we talk about engaging in client-led tracking and client-led goal picking, so to speak, and also co-learning about risks of a client's substance use or behaviors. It's also providing a lot of psychoeducation, which is really falls really well in line with CBTp, and not taking the expert role. And it's always exploring safer use strategies. And so some just simple examples would be obviously like a needle exchange program, ideas for like eating before and after drinking or using, and making sure to use in a safe place if you have the ability to do so. And again, it refers back to a person's own expertise on their own body and mind. So they have a CBT and harm reduction. I like them together because they have a lot of similar language, and a lot of it is about reducing distress and improving quality of life, and also meeting a person where they're at. So, and the normalizing piece of things is also important, and I'll talk a little bit more about that in my example. So I'm going to talk a little bit quickly. I know I don't want to take up too much time, but a person that I've been working with for quite some time in terms of CBT sessions. And so he's 25. I've been working with him for over a year now. And so he has schizoaffective disorder, and he identifies as half white and half Mexican. These are his words. And he is really a really interesting person. He went to college at a really great school on the East Coast, and he noted psychotic symptoms that started like pretty early on in college, and that he was drinking pretty heavily during that time. One, because it was sort of like the cultural norm, as we all know, and he started noticing that it was really helpful in alleviating his symptoms while he was working or while he was attending classes. So he really started drinking like very heavily, more than his counterparts. And he noticed that, but he knew that it was helpful to him in terms of his psychosis. So he did end up getting some treatment there for what they thought might have been depression, but ended up eventually being schizoaffective disorder. So he moved over to Seattle and started getting pretty more formal treatment here in our clinic. And he basically started taking medications that made him sick to his stomach. So he actually stopped drinking at that point because he couldn't. He would throw up every time he drank. And so this was obviously, it was an interesting moment for him to see how much alcohol he had been using and how it was sort of affecting his life, and how it was either not effective or effective for his symptoms, depending. And so eventually those medications were actually changed, and he started drinking again because he was able to. And so this was another interesting moment for us to talk about what he wanted to do with his with the alcohol. And so I brought in the more of a harm reduction response to this, to his back to drinking. And I showed him this I guess it's a worksheet, I guess, or an infographic about safer use strategies, because he identified himself that he didn't want to drink as much as he had been, but he didn't want to be abstinent. So I took that to mean that those were his goals, and so I didn't want to try to push my agenda, because I'm trying to keep out of the expert role. And so we looked at this, and he decided, a lot of safer use strategies for alcohol, like there are ideas for staying healthier while you drink, ways to change how you drink, and ways to make your drinking safer. So as you can see, there's a lot of different ideas, and he picked out consuming like less ABV for his drink. So he was drinking like Coors Light instead of like a higher like malt liquor. And he wasn't drinking any hard alcohol. So he would stick to like a 5% or below for his drinks. He also wanted to take days off of drinking, and he wanted to make sure to eat and drink water during, so that it could help sort of mitigate the absorption in his body. So those are just some examples on how I used this. And this is from the Heart Center, which is Susan Collins. There's a website at the end that I put some links to. She has these like infographics or whatever, I don't know what they're called, a worksheet thing that you can show people to choose kind of what they might want to, if they'd like to choose any of those options, to maybe have a less risky use, essentially. So the other thing that we talked about, and so this is the same client, is his cannabis use. And so this has been ongoing, and he's been using since he was about 15, and he feels like it's kind of a way of life for him. And so he does have some asthma and breathing problems, and he also has what he calls a throat or swallowing problem that basically medical workup at this point, they can't really figure out what it is, but some people said it was like anxiety. Another doctor said it's something else, and he's doing some like physical therapy for it, but basically he feels like he can't breathe or swallow. And so obviously that's super distressing for him, and then sort of creates like an anticipatory anxiety about it happening. But one of the things that he believes helps is weed. And he we talked about potentially him stopping smoking, and if he was going to use cannabis, that he would ingest it, so either through edibles or a tincture. And so he decided that worked better for him. He did some experimenting on what that looked like for him, and he decided to go with that and stop the smoking altogether. So he is still using THC, and we also looked at the research together around high THC content, and we do know that THC content has gotten way higher than it used to be in what you can just buy in stores. And so we looked at what the percentage of THC is for the stuff that he was using, and perhaps combining it with higher CBD to THC content to try to mitigate some of the paranoia that he was getting at times. So I'm trying to go quick, so if I can always answer any questions about that. But so he ultimately chose that he didn't want to be abstinent from cannabis, but that he did want to use a more balanced blend of THC and CBD, which we know that the CBD can essentially stop the THC or make it harder for the CBD to bind in your brain. And so it is sort of, in a non-clinical way, it like lowers how much the THC might affect you in terms of paranoia. So that's what he learned from his own research and his own body. So yeah, so that's kind of some examples on how I used some harm reduction strategies in a session with CBTP. These are just some more ideas for downers or depressants. These are safer use strategies, and for stimulants as well. And so I can probably send off a link to the PDF versions of these if people are interested. Otherwise, there are some websites that I put at the end. So, one of the things about that I wanted to touch on, because Sarah and the Echo Clinic had sent me some information about, Dr. Kilmer, which I wasn't there for this didactic. I think it was maybe in a first episode Echo call. But I did read it, and watched it, and it was interesting because they do talk about cannabis for psychosis is like, there's not a safe amount essentially to use that you would recommend, especially for people who might be at risk of first episode psychosis. So I want to be clear that I'm not saying that I was telling him to smoke or to use cannabis, that these are his choices, and we just learned together on what might be better, less risky for his body, and that there are some interesting, I think there's I don't know how to say this in a way that, I think with motivational interviewing, sometimes we can kind of get into a trap of thinking of what the goal should be for the client and what we think might, because we know, through evidence-based learning that it would be better that he not smoke at all. We know that, but to try not to take that expert role, it is really trying to find a way to balance, not allowing the person to have the goals that they want around their substance use, and not trying to kind of push the agenda. Although I think there might be clients that, this is just for this client, that it was helpful to work with him on more of a collaborative learning style with this. So anyway, I don't know where I was going with that piece, but let's see, how do I go back? Okay, so some other areas that you could consider using harm reduction would be in smoking, cigarettes or tobacco, in sex work or sexual encounters, or just any risky or unwanted behaviors. That the idea would be that there's a continuum, and there's really, really high risk on one side and less risky on the other, and it's finding out kind of in between there, is there somewhere that the client would like to kind of land in terms of how that looks for their goals. So that is that's a super brief rundown of harm reduction, and there's so much more to say about it. But so I'm curious if people have thoughts or questions about that, or if how they've used maybe some of these techniques in their sessions.